Thank you.
Thank you, Professor Raja. The pleasure is, the honor is also mine. In the next few minutes, we're going to discuss about an entity which we come across rather frequent in our clinical practice. It is, you see the title, it is patients with an embolic stroke of undetermined source and patent foramen ovale. Usually we use the acronym PFO instead of just saying the whole term patent foramen ovale. So what is this story about? It is about those patients who have a stroke. We try to look for the cause. We do not find the cause except for this PFO, which is a small hole in the heart of the patients, as we usually call it. So this is what we're going to discuss today in the next few minutes and see what is going to be our approach in terms of diagnostics and in terms also of therapeutics. So generally, this is the algorithm that we can consider using when we have a patient who has a stroke. So when we have a patient with a stroke, the first thing that we would like to assess is what type of stroke this is, and the main two directions that we would like to look for is whether this stroke is caused by embolism, something which started from the heart or the arteries of the patient usually and moved to the brain and obstructed an artery of our patient, or if this stroke is not of embolic origin and it is due to a specific disease which is happening inside the brain arteries of our patient, which is called small artery disease. I'm not going to go into this discussion. It will take us along, but generally, this is the first step that we would like to keep in mind to see if our patient has a small artery disease stroke. It's not rocket science. It's not that difficult. Most of the times, our radiologist provides at the letter of the CT or MRI some wording which shows that this is a small artery disease stroke. You can say so if you see a stroke which is deep in the structures of the brain around the ventricles, periventricular, and you see a small infarct which is usually in diameter less than 1.5 centimeters. If you see something like that, then it is a disease, is a stroke which is caused by small artery disease, so it's not embolism. In that case, the clinical implications is that you don't need to look for other causes from the heart or from the arteries of our patient. So in this case, if you extrapolate that, it means that you don't need to look at all for a patent foramen ovale, for a PFO. So if our patient has such type of stroke, then we forget everything about PFO or whatever. Then if it's not that type of stroke, that is, for example, your patient has an infarct which is located at the periphery of the brain, at some lobar area of the brain, then you need to look for something which embolized into the brain. And there are two main areas that we would like to have a look at. The first one are the arteries of our patient, and the second one is the heart of our patient. For the arteries, nowadays we have very good imaging methods like CTA, like MRA, so you can really have a good look at the arteries of your patient and see whether there is some clinically relevant atherosclerosis there. Now, what do we mean as clinically relevant atherosclerosis? For many decades, we kept thinking that this means that our patient has a stenosis of less than 50% ipsilateral to the infarct. But now we're moving away from that, and we have started realizing that it's not only about the degree of the stenosis, but it's generally also about the quality of the plaque. So your patient might have a stenosis which is less than 50%, but still this plaque might be very bad looking. On the other hand, your patient might have a 70% carotid stenosis, but this plaque would be may look really, really good and might not be the case of the cause of stroke. But this is again another discussion. So if there is nothing from the arteries of our patient, then the next step would be to have a look at the heart of our patient. And there are several things that we would like to focus on in the heart of our patient. That is in terms of electrophysiology, to see whether there is atrial fibrillation, and again, what type and what burden of atrial fibrillation in our patient. Then we would like also to have a look at the aortic arch to see if there is some complex aortic arch atherosclerosis there. We would like to see the valves of our patient, the left ventricle of our patient, the left atrium of our patient, and also we would like to see whether there is this PFO, this patent foramen ovale. If this is the case, then we have to assess whether there is some, this is an actionable finding and we should do something for that. So this is what is a PFO. It's a hole between the right atrium of our patient and the left atrium of our patient, which is normally all of us will have it when we are still in our fetal period. Then at some time around our birth, it closes. But for some of us, it stays open. It stays patent. That's why we call it patent foramen ovale. And it's not very infrequent. Approximately 20 to 25% of us, of everybody, has a patent foramen ovale. This foramen ovale stays open throughout our life, and typically, usually, doesn't cause any problem. But for some patients, it might, and this problem could be a stroke. That is, an embolus, which comes from the right side of the circulation, goes into the right atrium, then passes through the PFO to the left atrium for a patient, and then moves to the left ventricle and to the periphery and might cause a brain or systemic embolism. So this is the story. This is why we discuss about PFO in patients with stroke. Now, is it causally associated or not? I mean, as we mentioned, out of 5 persons in the general population, 1 has a PFO. So it's not really a surprise to find the PFO in a patient with ischemic stroke. But is it causally associated, or it was just an innocent bystander who just happened to be present there? Always in medicine, in order to assess a causal association between 2 entities, what is useful to see is to see whether there is some response to some type of treatment. And that was an ongoing discussion for about 20 years, but now we do have the answer. We do know that some PFOs are really causally associated with the stroke of our patient. And how did this conclusion come from? From those 5 nice trials, there were 5 very good randomized controlled trials where patients who had a stroke and had no other apparent cause, but had a PFO, they were randomized either to have their PFO closed or not. And they prospectively followed those patients to see whether they might have a stroke recurrence. And what they found was that the reduction in the risk of stroke recurrence was the relative risk reduction was more than 50%. That is, for patients who have a stroke and you don't know the cause and they have a PFO and you close this PFO, these patients, they have more than half the risk of having stroke recurrence compared to those patients that you do not close the PFO. And if you see the number need to treat, it's rather high. It is 46, especially taking into consideration that this applies only to a duration of follow-up of approximately 2 years. So it might be the case that if you follow those patients for the longer period, this number needed to treat might become even lower, although 46 is really an excellent number. But it is a bit, it's not the same for all patients. It gets a bit personalized. And there are 2 parameters that we have to take into consideration. The first parameter is the patient himself or herself. That is the degree of comorbidities which are present in this patient. So we have this score, the ROPE score, which is actually something like the CHA2DS2-VASc. So there are several cardiovascular comorbidities like hypertension, diabetes, smoking, whatever, and you get some points for each one. So if you have a perfect health, then you get a ROPE score of 10. That is a very good health. Now, the more comorbidities somebody has, the lower the ROPE score goes 9, 8, and whatever. So if you have a patient, what's the idea now behind the ROPE score in patients with a PFO? If you have a patient, a young person, for example, you have a 50 years old lady who has a stroke, no other apparent cause, she has a PFO. and this patient has no other comorbidities which could cause stroke, like arterial hypertension, diabetes, or whatever, then you don't have any other cause. This seems to be caused by the PFO. On the other hand, if you have a patient who has several comorbidities, that is, the ROP score of this patient is rather low, then you start having doubts that, yes, but perhaps PFO is not the answer to the question. Perhaps some other comorbidities might have been the cause of stroke. So, taking into consideration the ROP score of our patient, it can give us some clues whether this PFO might be causally associated or not. And you see how it works. You see in these randomized trials for patients who had a ROP score more than 7, that is, that they have very few comorbidities, there was a huge beneficial effect. On the other hand, in patients who had a low ROP score, that is, several other comorbidities which might have been causally associated with a stroke, then the effect was not that huge. So again, it points towards the direction that taking the whole profile, the overall profile of our patient into consideration can give us a clue whether this PFO was causally associated uh, or not. Another parameter that we should also keep in mind and take into consideration when assessing the causality of a PFO is not only the patient himself or herself, but also the PFO itself. Not all PFOs are the same. Some PFOs, they look really ugly. They have a large sand with a lot of sand going from the right to the left atrium. Some others, they might have some aneurysm next to it, the atrial septal aneurysm. So those two, mainly those two, the large sand and the presence of atrial septal aneurysm, they are associated with higher risk of stroke in patients with PFO. So these are two characteristics that when we see them, we think that PFO is not really that innocent. And these observational associations were confirmed by the analysis of those randomized trials. You see at the upper panel for PFOs which had ugly characteristics like atrial septal aneurysm or like large SAD, then there was a huge effect again by PFO closure of more than 60% relative risk reduction and a wonderful number needed to treat of 30. On the other hand, on the lower panel, in patients who had a good-looking PFO without atrial septal aneurysm, without large SAD, then the effect was not of statistical significance. So these are the two parameters that we would like to keep in mind when assessing a patient with a PFO, that is the patient and the PFO. And if you combine those, then you get this classification that was introduced a few years ago, the Pascal classification, which takes into consideration both of those parameters. That is the patient, you see on the left column, at the left column, the higher ROP score, that is the patient, the comorbidities of the patient, and then you also take into consideration the characteristics of the PFO. This is the middle column, and mainly whether there is large sand or and there is an atrial septal aneurysm. So by combining those two, you can really have a very good estimation of whether this is causally associated with the stroke. For example, let's see at the last row. I'm sorry. Let's see at the last row. You see if your patient has a high ROP score, that is, has very good cardiovascular health, no other comorbidities, and there is an ugly-looking PFO, then it is really probable that this is a PFO-related stroke. On the other hand, if you go at the first row, you see if your patient has a low ROP score, that is several comorbidities, this patient is diabetic and hypertensive and blah, blah, blah. And if PFO doesn't look ugly, there's no large sand, there's no septal aneurysm, then it's rather unlikely that this is a PFO-related stroke. And you see the lines in the middle. If you have combinations of those, then it might be possible, but you're not really sure. So this Pascal classification was again confirmed by the analysis of those trials that again you see the effect estimate. You see at the upper panel, at the lower row, you see if a PFO or a patient was considered as probable PFO-related cause, then the effect estimate was huge. You see more than 90% reduction of the relative risk for having a stroke recurrence. On the other hand, in patients who were unlikely to have a PFO-related cause, then there was absolutely no beneficial effect. So it seems that the Pascal score works well to give us a good estimate of which PFO is causally associated with the stroke of our patient. In this case, if we have such a patient, then the next step would be to close the PFO of the patient, but with an asterisk. All those trials that we discussed were trials of patients who were less than 60 years of age. They were younger than 60. So for the moment, we do know that if you have a PFO-related stroke, closing the PFO will help. For the moment, we know it only for those patients who are less than 60 years of age. For the moment, we do not know if this is the case also for patients who are older than 60 years of age. There are some ongoing trials, but we're not there yet. So for the moment, and that's the take-home message, if you have a patient who has a PFO, it looks causally associated with a stroke. If you have such a patient, then your patient is younger than 60, then do suggest PFO closure. Your patient is more than 60 years of age, then hold yourself and do not recommend PFO closure for the moment. Thank you very much.